everyone. Thank you for everyone that is joining us for this first edition of the flash courses of the International Society for Telemedicine Health and its education program. My name is Jefferson Fernandes, and I will introduce some information first for you for this edition of the flash course. I'm going to share my screen and start with this presentation here. So for those who do not know yet the International Society, we are the main international society in the field of telemedicine health. And the mission of our society is to facilitate the international dissemination of knowledge and experience in telemedicine health and providing access to recognized experts in the field worldwide. This is what is going to happen today. The education program was created last year with the International Society recognizing the importance of education in this field. And then this program, which is my responsibility, I'm now honored to be the director of this program, is to organize several activities fostering education, fostering the participation of people from all parts of the world. Just to let you know some specific strategic goals, we are responsible for the coordination and the management of the education activities of the society organs. That means the working groups that played an important role in information and technology activities. There are several working groups, and if you go to our website, you can see the list of them, what they are doing, and we invite you to join the specific working group that you feel attracted by the topics that this group is working on. We also have the CONEDIC, which is the Consortium of Education Institutions Digital Health. It's an initiative that works with several academic institutions. And then the student membership, which is a special subsection bringing students together with our society. We have developed now, with the coordination of Dr. Simone Farah, a prize. We're going to have this year 2 sessions where students, pre-selected students, will present their work in telemedicine health, the results, their experiences, and there's going to be a special judge to evaluate them. And in the final session, we are going to select the 3 best projects. So we invite you to access also our website to see this student membership prize, which is very, very interesting. Within the specific strategic goals, we also foster key education training projects in concert with other organs, building up education projects in partnership with institutions, with organizations, and education projects as this one, the Flash Course series, and we also have webinar series from the education program. And finally, we have built this endorsement of education programs. You can see here the seal that was created, and we already have 3 academic institutions that requested this endorsement. We proceed for the evaluation process within a committee in the International Society, and evaluating and providing the endorsement once we understand that this course achieve the standards that we think would be required for that endorsement. So this is a quick view of what we are doing in the education program. And today we're going to do our first course from the Flash Course series. And we have this course series is provided by members of the International Society, different from webinars where we can invite people that are not necessarily members. These are courses that we have the participation of our members, people that are experts in their fields. And today we're going to have 3 of the 4. I will let you know soon why I said 3. But we start with Neja Brenčič. She's going to introduce more herself when in her turn. Neja is from Slovenia. We would have Richard Dasselaar from the Netherlands. However, unfortunately, a few hours ago, he has a car accident. Nothing to worry. He's fine. He's well. But I know he's dealing now with these problems of a car accident, all the aspects that deal with these documents and problems with cars, and also he has a bit pain and he's not being able to join us, unfortunately. And so he's going to participate in the next editions of the course. We have planned 3 editions. The first is today. The next one is going to be on September, on the 22nd. So please, now include in your agenda this date. And then the other one will be in November, and the date is still to be announced. We're going to have also Ahmad Awada from United Arab Emirates. He's going to introduce himself. And also Emmanuel Abara from Canada. He's not here at the moment with us. He's in a flight. Hopefully he's going to reach the hotel room in a few moments. So we hope that later on he will going to join us for this course. So these are the dynamics of life. Sometimes we plan and something happens and then we have to change our plans. But anyway, we are here to present the knowledge, experience, and visions of experts. And we are going to start with Neja Brenčič. Neja, thank you very much for joining us today. Please introduce yourself, and then you can start with your presentation. And just before that, I forgot to mention, please, if you have questions, you would like to make comments, use the Q&A icon or the chat, but it'd be easier if you join everything in the Q&A. And after each presentations, and also in the end of all presentations, we are going to come back to your question discussions, and the discussions will be together with all experts, with all speakers. But let's listen to Neja. Neja, the screen is yours.
Okay. Thank you so much, Dr. Fernandez, and also to ISfTeH. It's a great honor that I have an opportunity to speak. I will share my screen now. Here's my presentation. So as Dr. Fernandez has kindly announced me, my name is Neja Samar Brenčič. I come from Slovenia, and I have a privilege to be a chair of the ISfTeH Standards and Accreditation Working Group. So just to put some faces and names together, you are all probably know Frederick Livens and Dr. Malcolm Fisk, who's an expert advisor to the working group, and also Dr. Drago Rudal, he's a vice chair of the group. So what is our agenda? What is our vision? We believe that standards and accreditation for telehealth services improve the quality of patient-centric telehealth services worldwide. So we believe that the person should be in the center of everything that we do regarding the telehealth and also telemedicine medical services. So ISfTeH is, our working group is basing its work or our work on WHO Global Strategy for Digital Health, also the EU Action Plan for e-health, and telehealth standard, the technical standard 13131, and of course the International Code of Practice with patient-centric design. Oops, it doesn't want to go forward. Sorry. It should move.
You can just press enter.
Okay, thank you. What is our vision also, as I started, it's the standards and accreditation for telehealth. So our working group wants to provide an environment where everybody would work together to create standards and associated frameworks to improve the quality of patient-centric telehealth services. So not only the patients, the patient groups, but researchers, innovators, developers, companies, and policymakers, which is crucial to our cause and to the process that we are involved in. And also trust. We never cease to emphasize the trust that we need to create an environment where telehealth services and telemedicine services will gain trust from clinicians, social care workers, carers, service users, everybody, again, who is in the process. We believe that this is the basis of successful and sustainable telehealth services. More of our mission, since we have a little bit more time on our hands, and just to put some meat to my presentation, I think that we are very much involved in all these objectives. So to support technology, innovation, business, and professionals in enabling this experience of telehealth and also the telemedicine to reach people, to reach developers. And why I'm saying this is because later in my talk, I will present a use case which really opened my mind, and it has to do with our mission as well, like that. So what are the possibilities of the standards development? So we see, I think it's important, it's crucial even to have the standards involved or be a basis in international strategies. So to have standards in international strategies, European national strategies. Sorry, I'm coming from the European context, so it's also in South America, wherever in the world. So the strategies, the national strategies, we need to work on. And I think now we have the momentum from this unfortunate COVID situation, but to just stay with this momentum and work on it to really reach, to get some effect from it. So the procedures and service protocols for such treatments where they require standardization to have the quality, to reach the quality or to maintain the quality. And also for the patients, so the patients can afford new choices in the way they access their health or their data, and how they're provided with support, with health support. So I know that, as I said, COVID was a great endorser of this change, but I think I'm amazed how people, we are, how adaptable and how creative we have been, or we have proved to be in the last years, or anytime if you imagine. But in this regard, with digital health and the standards related to this, since I'm speaking about standards, I'm amazed how we adapted to these new situations, how we have developed also. Like, for example, even in the last year, the update of the ISo-TS 13131 came out, and so this is like, I can say to myself and to my colleagues and to people I reach out to, that there is no problem that we cannot face and find solution when we work together for a common cause. And also, this is a very good and noble cause to provide for quality in telehealth and telemedicine. So what does standardization bring to users? When I speak about users, maybe even a couple of years ago, I would also have in my mind the patient or somebody who's at risk, somebody who's a risk group, somebody who needs help. And then during these last years, when I was so much involved in the procedures, in the hospitals, in the with the developers, with medical staff, I see that we need to focus on every person within this process. So it's not just or only the patient who receives, who's at the end of this service, although in such a vulnerable position, but every person in the process. So every medical worker, carer, service provider, technician, everybody, we need to think about these people in the process. Also about standardization to help them through standards to provide better care, and also for them to be in a way protected when in the workplace, to be protected and guided or guarded by the standards that are in place in that facility or in that process or in that service. What also brings, the standardization brings affordability, and it also brings access to the services. So again, I would say trust is at the end, because trust comes with good experience. And so when we provide with the standards by which people can work, by which people can develop, by which people know what is coming for them, what is in the future for them, or in the service for them, then when they have a good experience over and over again, because this procedure is standardized, then this builds trust. So that's why the standards and standardization is so crucial to the digital health service. What are some examples of standards? I know that everybody is in the rush, not just to, we're all in a rush to keep the pace with the development. And as I mentioned, telehealth standard from ISO, there's standards that individual companies or organizations are developing. And also in ISfTeH, there is a group, Telehealth Quality Group, that was kindly and synergically involved now with the ISfTeH, that provided us with the code. So the telehealth standards, the guidance and sort of guidelines and procedures, everything in there, that is also kindly being published by ISfTeH and is available to all, not just to all members, but all the public, so everybody can share with that knowledge, extensive knowledge of this telehealth quality group and ISfTeH by having this code available. So that that is a great gesture. So now coming to this case study that we've been, I had a privilege, or my team and I had a privilege to do the pre-assessment of all telemedicine services in Slovenia. Slovenia is a small country, so in this regard, we are lucky to have this sort of a testing ground or research ground where it's maybe easier to access people who are in development, in management, and so on, to provide us with this opportunity. But it's a nice way to present this case. So we had this privilege to assess these organizations, even the National Institute of Public Health, with the national e-health, electronic health record. They developed the teleradiology, teletransfusion, telestroke, teleconsultation, and so on. So they have a number of telemedical and telehealth services and e-health services. Then also Telekom Slovenia, they have the e-health, e-care, and e-work health, and some other related services. And then the Medical University of Ljubljana with the Telefarm, and a lot of private companies. So we assess together 14 entities with 21 services. What we have learned from this process, I'm sure that similar things are going on in all of the countries, but maybe this is a little bit, again, specific because it's a small country, a lot of developers out there who are developing services and solutions that are also internationally used. But let me start with the graphs. So this is a selection of questions, of course. It was a little bit longer study, but that just, I chose some of those that I thought were more intriguing. And of course, at the beginning, we asked them, what kind of services do you provide or develop? So we can see, I'm sorry, the graph is in Slovenian language because we conducted the assessment in Slovene. So medical personnel to medical personnel, it's 57% of these companies or services are medical to medical. Then about 30 is medical to patient, and there are then others, other services, other kind of services. And amazingly enough is that everybody who is providing, who was in the assessment, everybody is involved in some way in the service development procedures. So we can say, although there is a, they're on the market and they are competition, but we can see that basically many of them are working together, even in some way, at least sharing knowledge and experiences. But to me, it was intriguing that 100% of them are involved in the service development as well. So how do they know standards? How well they know standards? We can see that I know about standards answered about the 77% of respondents. And these were not only, the research was done through questionnaires, but also through semi-structured interviews. So we could gather more information and understanding about even what a standard, a telemedicine or a telehealth standard is. And what is a standard of a technical standard, what is a standard for IT, for connectivity, and what is a service standard. So we could even see that here the, not the confusion, but the mismatch of understanding of this subject is. So we will have to do some further research and about this. But anyway, so people know about standards. They actually use, like almost half of them use standards, but about a quarter of the respondents don't know about telehealth or telemedicine standards. And what for me, it was a little bit humbling, or how can I say, it was a curious situation because when I introduced them about the research, and I want to research about standards and their development, and people were, how can I say, they were a little bit uneasy, because what we found out during the assessments or the pre-assessments was that they sort of, we see standards as something that we need to really, the standards are there to limit us, or standards are there to make trouble. But so we had the chance also to talking and with these people for a little bit through these assessments, that we could tell them the standards should be or are there to be a sort of a guidance. So something, when you do that at the early beginning of your development, then it's something that will help you develop a better service, and that something that will help you further on, that you will not have so many problems with the service. Everything will be easier when you think and when you abide to standards. So, but this is interesting. It's sort of a psychological, aversity to the word standards. But most of them, we also found out that this knowing about standards was in regards to the connectivity standards. So not about the telehealth and telemedicine standards in a sense of service. So when we asked them, do you follow standards even if not certified, in a sense that they might know about standards out there, they don't follow them completely, but they would sort of lean towards, they would use these standards or parts of the standards to help them develop or their service. So this was actually quite a high percentage of these answers. So about 85 would use some sort of standard for their development. And then also we wanted to know if they use standards in their development, in a sense, does the company have any other standards that they have, like risk management or ISO 9001 and so on. We wanted to know about it just to sort of also guide them, because we will continue working with them through this assessments. Wanted to guide them to see that if ISO 9001 is a good thing for you, then maybe some other standards as well good, and you should not be afraid to start using them, and in that sense. So that's why we asked them, what do you see the main benefits of the standards are? So quality, clarity of procedures, efficiency, and satisfaction. So most of them would say they could choose more than one, was quality and the clarity of procedures. So this was their response. And then as we were discussing also what they see for the future, how they see the standards in their development in the future, what would help them, because basically this is also one of the visions of this activities, is to introduce them to telehealth and telemedicine standards, and not to make them feel bad, because basically these standards have just been developed in the last year and a half, or even in the last year, and are only now available. And what to do if you have already, you've done so much of development, and now you have to go back and use the standards. What do you do? So these kind of discussions were going on. This also was a point that they would consider education and training in standards. But in standards, this was a nice way to say useful standards. So I think we're getting somewhere that to help them understand that the standards can be useful, and not maybe every standard is for everyone, and to help them through training and education what is best for their business. So they would also appreciate standards as guidelines and information sharing. So these were some of their responses. So what would be my conclusion or my concluding thoughts about this is that as I started talking in the beginning, I think it's really important, and it's also one of the goals of our working group to influence the policymakers. Even here in Slovenia, or neighboring countries, or some other countries where I'm more involved in these processes, and in advisory boards of strategic boards and so on. Yeah, I can see that there is a lot of work for us still here to help standardization, to help standards be a part of the strategies, of the health strategies. I believe that the standardization of services should be an underlying benchmark. So there's the technical standards, or that they have, like the standards that are in this regard more developed or more used. Of course, if that doesn't work, no service will work. But with the services, there's still a lot to do, in a sense that we need to educate and inform and provide also the programs that will help companies adopt the standards for telehealth services. So this is about it. And my maybe a very concluding thought is that we are here on the on the frontier, working with telehealth and telemedicine issues, and we need to understand there's always a person, as we're people, and we are dealing with people, not just technology, and we need to focus on a person, not only on financial benefit, but not also just on technology. In a sense, it's so intriguing, even for me, working with technology when so many things is possible, when you can see such a development. It's so, yeah, it is intriguing, and sometimes it takes you away from the real person, and that is from the real problem or issue, and that's the benefit of a person. So this would be it from my side, and thank you for your attention. And I'm open to any questions or discussions in the next minutes. So thank you.
Thank you very much, Neja, for your insightful presentation, bringing the results of your research. That is very important for understanding what people in the field, people that are working, really understand and practice. I think, just as an initial comment, the question of standards involve deeply the safety and the quality of care that we are providing, not only the professionals, but also the organizations and the companies for taking care of patients through telemedicine, through telehealth, or through other digital solutions that might be directed to patients and their relatives and to people as a whole. So thank you very much. We're going to start to bring to you some questions. We have several questions here. If you go to chat, you can also follow. I'll read them. I have several questions from Frank Goldberg, but I just jumped to one comment before going to Frank questions. A comment from Krishna Sharma regarding the telemedicine consultation in medical education and health wellness innovation, remote patients more into some maybe possibilities. I think the point that I would like to stress here from Krishna comment is that we need to foster more educational activities in different levels, and the graduates, the students of medical courses, health courses, or even from other professions that are involved in digital health as a broad and generic term, and also for the professions that are working and or starting to work in these fields. So this is truly important. Now, I always say that telemedicine, telehealth, teleconsultation, in my view, they are not tools. The tools are the hardware, the software. Teleconsultation, telemedicine, telehealth are methods of taking care of people. And as a method, they should be learned. It's different from people to do an in-person consultation from a virtual consultation. There is a lot of differences, and how to make this consultation, virtual consultation, as good or as the same level of an in-person one. And this goes on to the organizations, so the companies, bringing the topic that you were talking about, standards, which are very, very important in the terms of improving the quality of and safety. With the pandemic, there was an exponential increase in several countries, and I'm sure that in several, not say in a country level, but several services, the quality is not that we should that should be proceeded to take care of people. So I think this is a very important topic. So I'll move for some of the questions of Frank Kalberg. Thank you, Frank, for being actively sending questions to us. I stimulate other attendees also to send their questions here in the chat icon or in the Q&A icon. That's the way that we are going to make the discussions, and from your side, we will not be able to open the microphones to you, but please write your questions here. And it's just as a side comment, it's nice to see that people are presenting themselves, bringing their LinkedIn address, because this is one of the opportunities that we have to do networking. Virtual meeting like this is also this opportunity. But okay, let's go to one of the first questions, comments of Frank, which is Frank Kalberg. Can you please elaborate on what are the key reasons for people to rapidly adapt during the COVID, for example, to technologies like Zoom and other media to share experiences and ideas to each other? In other words, why was change, innovation so much possible during the pandemic than before the pandemic? What's your...
So this is a little bit philosophical question,
yeah.
And a complex question, a very complex socio-psychological. But to just make it simple is because we had to adapt. Maybe the next one is that the resources were focused into this development. So resources for like, I don't mean just the money, but all the resources were forced into this innovation, or not. Yeah, so I think that's, but what I wanted to stress is that people, we are able to adapt, and this is a positive trait of everyone. And so that's basically what I wanted to say, just that people are adaptable, and it's a good thing.
All right, thanks. The next question from Kalberg is, do I understand you correctly that standards first, strength, efficiency, quality, safety, reliability, stability, but second, reduce creativity, agility, adaptability, innovative ways of working? So this trade-off.
Yeah, I understand. I was basically what the standards do is the first part, the number one. So strength, efficiency, quality, they do not reduce creativity, but that's what people might think when they start learning about standards. Maybe a better word for standard would be a guideline. Mm-hmm. So when you say a guideline, that's like a positive, okay, somebody is guiding me somewhere where I can or I want to go, but the standard is just like, yeah, it's a bar that doesn't allow me go where I want. But actually this, the standard is like a pole. If you had any experience of growing trees or some other vegetables, you know, you need to have a pole that holds up the frail plant before it reaches its maturity. And this is how I see standards, and that's how the standards are developed for the quality of the final product to help you go up.
Yeah. And just to add to your comments, no, these are not things that are they can be dynamic. No, there is evolution, and each time we learn more, each time we have the practice, we understand that some things should change. So it's not something that is there, no, such as a statue that is there forever. You can change it in a dynamic process. Of course, it takes time. There is a method to build up standards. There are criteria, but also we know that things can be changed, and the evolution is something that is important. And creativity, as you said, is not compromised, because we can be creative with several other aspects of developing products or services. And coming to that, the following question is, what are the process for developing standards? This is a very wide question. And to what extent is the continuous development standard transparent, open? And it's also, to what extent is the development of standard crowdsourced? So it's again regarding the way of developing standards.
Yeah, so different organizations have different procedures, how they involve the experts or those who are developing standards within that organization. It's usually done in a way that you have various expertise that work towards a standard, and it's a longer procedure. It goes through processes that evaluate the standards. It's evaluated against real life situations. It's evaluated against the studies, the case studies, and that's how it is developed. And it's the standard is also, like, for example, we see in ISO TS, the 1331 that I mentioned a couple of times. It was the edition from 2014, and now it has been updated and aligned with the situations in the world and in the medical field and in the development, and it got the edition of 2021 that we are now using also in the assessments.
Right, wonderful.
It's
and to what extent,
yes.
Yeah, sure. Yeah, this is a good point to make. And Neja, to what extent and how do you use artificial intelligence in your work?
In our work, we don't necessarily use. I'm not sure how this relates to that. To our studies, we just use we don't use the artificial intelligence.
Okay. Right. Thank you.
Standards, yeah.
Thank you. And there's a question now from Ala Kari, and the question is how to join work groups to form guidelines. Could you share the process? Sorry, I'm not sure if it's he or she. I'm an expert in teledentistry and want to work in this area.
There's a procedure how to join the groups. You can go to the website, the ISfTeH website, and they will, there's like a formula how you apply as an individual. You can apply as an individual, but you have to be a member of ISfTeH. So first you need to be a member, and then you can join the working groups.
Wonderful. And I stimulate everyone.
For the link for you, yeah.
Yes, ISfTeH.org. You go there. You can now look for the working group standards and accreditation for telehealth services, which is chaired by Neja Brenčič, and there are also other working groups, and we are willing to have more people working together with us. We are an international community, and every contribution, every participation, every experience share is important for us to growth. Frank Kallenberg is thank you very much, Neja, for your feedback, much appreciated. And also Alfred Camara, thank you for your brilliant presentation.
Thank you for being here. Yeah.
Thank you very much. Okay, wonderful. So I also, just again say for you, please, if you want to bring your questions, use the chat and Q&A icon. And now we are going to have the participation of Ahmad Awada. Please, Ahmad, thank you very much for being with us as well. And please introduce yourself, your work, your activities, and the screen is yours now, Ahmad.
Thanks, Dr. Jefferson. I'll just share my screen. Thanks, everyone, for being here today. I'll be happy to take you through the digital health interventions for chronic care. A quick brief about myself. I come from extensive technology background, and I was very lucky in 2015 to co-found a company for telemedicine. It's a company called Mobile Doctors in UAE. Later, it was branded to another company called TrueDoc. It was a quite interesting journey. I was very blessed to be part of the team that built and the framework here and created the standards for telemedicine with DHA. That's our local regulator. Currently, I work for a company called MediClinic Middle East. I look after the virtual health for our facilities and divisions. My goal, to be honest, it's to bridge the virtual and the physical worlds of healthcare. That's why I'm here. I will be very, very happy to connect with any one of you to answer any questions. I really like the questions from Frank. I hope that my presentation will answer some of these questions. So this is the agenda of today. That's what I'm going to take you through, and some of these items will answer your questions on the adoption and the AI. So I start with the COVID-19 impact. Where I see it, the CIO of the year. I would say the CIO and the CEO and the CSO of the year, where everything was implemented really fast. I took the liberty to show you the utilization trend in MediClinic Middle East. We have 22 clinics, 7 hospitals, and we adopted telemedicine, I think, around April 2020. When COVID hit our facilities and we were not really able to see patients, so we had to quickly adapt it. And the patients also were not able to come and visit us. So before that, in my earlier company, which I worked for from 2015 until 2020, when we were trying to provide the telemedicine services to insurance companies or corporates or patients, we were always stuck with a couple of issues. First one is the insurance payment. Is the insurance covering for this service or not? Second one, and I think this is the most important one, is the patient's trust. The patients didn't have trust for these virtual doctors. And when COVID hit, they were forced, as Neja said, that they were forced to use it. And that's where they started realizing, oh, this doctor can manage my condition. And then it started to be adapted. But I will show you a very interesting journey that my company went through it. It started in April, and the first curve that we see there, it was immediate adoption. We started our telemedicine service, and immediately we had 3,800 consultations. Then it kept going up until almost touched 6,000. Then when the facilities opened, it deteriorated very quickly. in August, we were back, I think, beyond the level that we started with. Then we saw something very interesting happening, this curve, that there was slow adoption, slow increase, and then it started to explode. This one here, we have some technical issues, that's why it was dropped. But overall, it kept going. So the reactive curve that you see here, it continued after that because patients started having the trust towards the service. And they realized, yes, many things can be managed by having virtual consultations. Luckily, we passed, I think, last month, 130,000 teleconsultations in the past 2 years from the moment we started in April 2020. And we keep growing in this area. So the COVID-19 impact, I would say that it accelerated the patient's adoption. It enabled primary care. Lots of consultations were happening with the primary care doctors in our facilities. And this is something that I will explain why it's very important in chronic disease management in the next slides. And the patients took that as a new healthcare delivery method, a new model that they were not used to. Then it created the hybrid healthcare model, which is the mix of the virtual and the physical services. Earlier, before COVID, I would say that many of the telemedicine providers, including my earlier company, we were just sitting on the virtual world only, which is not ideal. A patient should not have a company for teleconsultations, a company for home care, and another company for primary care clinics, another company for hospital and inpatient. That's one of the biggest problems in healthcare. So the more that the healthcare is integrated, the more that you merge and integrate the virtual and physical within a single provider, the better for the patient, and it will enable him to access the doctor physically or virtually. Now, the most important thing when it comes to getting paid, it's the insurance companies or the funders. I think before COVID, it was provided to some networks, but not all the insurance networks. And this was seen like a value-added service, not as a real solution for the patient needs. So what we have seen in the COVID period, there was accelerated insurance companies adoption, where they immediately started having tariffs for these services. And actually, it solved many technology challenges that we had. One of the challenges that we had locally is the telecommunications authority regulations when it comes to VoIP technologies. The government was very active and immediately they started assessing some technologies and doing exemptions for these technologies to operate VoIP calls so we can provide the care to these patients. So this was the COVID-19 impact. Again, I see it as the CIO of the year because of the fast adoption of all the technologies around telemedicine. This is actually quoted from one of my colleagues in DHA. His name is Dr. Muhammad Rida, and he's always talking about it. And I really agree with him that the adoption that we have seen in the COVID period was really amazing. So I'll give you a chronic care overview. What's happening now in chronic care? Our systems, healthcare systems, are more reactive. So we wait for the patient until he's sick and he comes to the hospital. And this has a very big impact on the patient's health and in his health policy and the funding for that. There is a primary care effect happening everywhere in the world. And we see in the UK that 78% of the consultations of the primary health care doctors are for people with more than one chronic condition. And they do the doctors there, they do the coordinated care for a wide range of problems in one individual. So in brief, they don't look into only your cardiology condition or your diabetes or your hypertension. They look for after you from full health management, not only the symptomatic care or a specific episode or a specific condition, which is very important for future healthcare models. There is a need for integrated strategy. As I explained to you, there's fragmentation in healthcare, different providers doing different things, And there is lack of focus on the preventive care. And this is very important. I would say on our region, at least, the government policies are focusing a lot on the preventive care, but the funding for preventive care is not really strong. I think that's something that needs improvement worldwide. And this will help definitely in delaying the health deterioration and ensuring the continuity of care across the providers. The fourth point is the lifestyle impact. Many of the cases that we manage, we realize that there is a huge impact from the patient lifestyle on their condition. If they were smoking, if they were over-consuming alcohol, if they are obese, this all is really affecting their condition. And some studies, and you'll see that in the references, that 90% of the obesity, diabetes, cardiovascular diseases are contributed by a patient's lifestyle. The other thing that we see, which is not really common in UAE, the aging population. In United Arab Emirates, mostly we are expats, I think around 80% or 70% expats. The aging population, majority of the chronic patients over 65, they have one chronic condition, 80% with one condition, 50% with two conditions. There is a healthcare expenditure, and we see that increasing cost. I think after COVID, we became very attentive to this cost, because when the economy was going up, everything was fine. And I think the insurance was trying to fund the payers and the employers as well. So the cycle was easier than post-COVID, where now everything is being assessed to have a proper ROI and to drive real savings of managing these patients and better health outcomes. But in the UK, 64% of all the outpatient appointments and over 70% of all the inpatient days, those are estimated to take up to 7 in every 10 British pounds in total health and social care expenditure. That's 70% of the cost is going for these patients. And this is something that we usually discuss in chronic disease management, the percentage of patients that they consume the most of the healthcare fund or budget. And this is variable. It could be 20% that consumes anything between 60% to 80%. It depends on the country, depends on the population, the patient demographics, and all of that. The last point, the mental health, and that's, I think, a new area that telemedicine is trying to engage in it. There is a need for regular checks and engagement to ensure that depression does not affect the day-to-day functioning abilities of these chronic patients. If the patient has a mental health issue, and even if you put him in the best treatment plan with the best medications, it will impact his adherence and compliance of this treatment plan. Sometimes patients, when they get old or when they have multiple conditions, they give up on themselves and they stop taking the meds or seeing their doctors and doing the follow-ups and managing their condition. So it's very important to always engage with these patients and have models where you can do more of case management and disease management, where you're always engaging with this patient and you're always coordinating things for them, listening to their concerns, providing them with emotional support. LTC, as said by some doctors, love, tenderness, and care. So that's in brief what's happening in the chronic care. Now, there is a healthcare transformation trend happening, I think, all over the globe. And I'm sure you are all experts in your fields, and maybe you will agree or disagree with me. But as of today, we were focusing mainly on the sick care, where we treat a specific set of patients and we provide them with the best care when they are sick. It's provider-centric as of today, because we focus a lot on the provider, what's convenient for the provider, what makes him happy to manage this patient. That's in the, I would say, the old days. Episodic approach, that's what I was explaining about the primary healthcare doctors. We focus on a certain condition and we try to fix it when the patient is sick. And lots of engagement happening in the hospital for these chronic patients. Not to mention the invasive and uncomfortable when they deteriorate and they go for inpatient or emergency. And I think there is a push, there's drivers, as it's mentioned here, this slide from Dr. Arthur, I really like it a lot because it explains what's pushing us to go to tomorrow. And the biggest problem is the cost of healthcare delivery and the need to improve the access to care. So it's always the dilemma between cost and quality and access and all of that. And I think there is a pressure for us to decrease the cost, provide high quality, and to provide access as well. And that's something that we are all trying to solve using all of this digital health and telemedicine services. The complexity of care conditions for some patients where they have multiple conditions and the need to have more of holistic management methodologies for these patients instead of having 3-4 doctors managing them and the lack of coordination and continuity of care between these doctors. The increased patient involvement, the patients now became very involved in their care. I can tell you from MediClinic, the patients are asking for their Medicare records to have full access to that, and they would like to review it to understand what's good, what's not good. I think the patients now, they want to be in control of their health. Maybe COVID helped with that because people were sitting at home and they were panicking when they were feeling unwell, so they are trying to manage themselves. So how does it look like tomorrow? Tomorrow it's about health of citizens, the population health management approaches that you might be familiar with, where you focus on all population, you don't focus on certain condition or a certain acuity. It will be for the acute patients, chronic and healthy. It's more patient-centric. I would say that 10 years from now, you might not see all of these clinics that you see today. It will be the healthcare delivered to the patient's house, as many of the services that we are seeing today. And I can assure you that looking at the amazing IoT devices that we are seeing in the market for remote examination, where the patient can sit at home and use a device to take his temperature or put it in his chest, and the doctor will hear his chest. So I think the care is going to the patient's house, and this is migration of care. I think it happened before in the I would say between the 60s and the 80s, where the patients went from inpatient to outpatient. Now it's happening from outpatient to the patient's house. So it's about patients for the next period. Lifetime care and preventive, that's a huge focus. You don't just treat the patient when he's sick, you need to prevent him from being sick. And I will talk to you today about how this preventive care looks like for chronic patients. Decentralized and community-based, I've seen this model in Africa a lot. You don't need to have the deep integration of hospitals and systems. It could be what do you call it in the US, 1-minute clinic, like what you have in CVS. And I see more of that in Africa now. I think that's where they have the same dilemma of cost, quality, and access. It should be less invasive, invasive visualization and treatments. Yes, that's something that comes automatically with preventive care and all of these digital solutions. Another point that I wanted to tell you about is the IT transformation. I think many of us, when we try to implement all of these digital solutions, we get stuck with the limitations of our IT infrastructure. So the old models of IT infrastructure, that everything is in the facility. I need all the data, I need all the servers in the facility. And this slowly started to migrate when there were tools that uses AI, and there's a need to have these AI engines that require massive amount of servers. So there's no way for a healthcare provider to provide all of this infrastructure for this amazing AI that does analysis, for example, in radiology or another condition, radiology or another department. So hospitals started to be open about adopting cloud technologies. And that's where the standards and the guidelines came, when we started taking care of the patient information and the medical records, data protection and information security. And this was, I would say, in this region, in the Middle East, progressing very well. But this pushed towards going more on the cloud, where you use they started, I think, with the infrastructure as a service. That's when they started getting cloud servers. And then it went to platform as a service, then it went software as a service, and it's progressing. The more that you go to this model, the software as a service, the faster that you will be able to implement. Now, it differs from a country to another. What kind of software as a service are there? I think, again, UE here, they are doing a great job in vetting the companies doing telemedicine and telemonitoring and multiple things related to chronic disease management. They make sure that the data is hosted locally. They make sure that the video calling technology in compliance with the Telecommunications Authority, all of that, all the checklists, so you can easily adapt it. So you can go ahead and use a vetted software as a service solution. So how does it look like, the future of chronic care? The future of chronic care, the way that I see it, I've done chronic disease management since 2016. I was very lucky to build our system in my earlier company. We were using Cerner, but it didn't really meet our requirements when it comes to the digital world and expanding and being agile and all of that. I can tell you the first thing is the holistic treatment plan. This is very important. One of the biggest problems in the virtual healthcare before COVID, that there were always amazing chronic disease management programs, but they were not in coordination with the treating physicians. So the treating physician will take the patient to this pathway, while the virtual healthcare service with the remote patient monitoring and this amazing technology IoT is taking the patient to another direction. Now with COVID and having this integrated healthcare systems, it started to enable having this holistic treatment plan, where you can have 24/7 healthcare and at the same time have access to your doctor. Definitely your treating doctor is not going to work 24/7, but you'll have access to certain services 24/7, where you can speak to a doctor, you can intervene with you, monitor you. So the holistic treatment plan started to be created by the virtual team who's managing your condition and your treating physician. I would assume that the virtual team in most of the setups, they are primary healthcare doctors, most probably family medicine doctors. And in the treating physician, they are secondary care doctors, where you will have the cardiologist, you will have the other specialists and the neurologist, nephrologist, and all of that. And that's where there will be coordination between the virtual team, that they are always engaging with the patient, and the secondary care that that the patient will be referred to him when there is episodic care that requires his attention. The other thing that part of that is the periodic special consultation. You should not disconnect the patient from the doctor. It's very important to keep the continuity of care between the patient and the doctor. A patient before COVID and before these amazing telemedicine technologies, he was seeing this doctor for many years. He trusts this doctor. You cannot take this patient from the doctor. What you can do is empower both patient and doctor. You can provide these amazing solutions, so the patient will have better health outcomes, less deterioration and management of his condition. At the same time, the doctor will have all the insights on this patient and to help him to get better. The other thing is that definitely the primary care consultations, teleconsultations happening virtually, the nurse teleconsultations, it depends on in each country and your framework, but here we use nurses for the follow-ups and the management of these patients. They make sure that the patient is doing what he's supposed to do. And I will come to in a moment and explain to you the 3 types of patients that we look at. Then you have the amazing remote patient monitoring technologies, which I think it increased in the past period. Some of them existed before COVID, but they were not highly adopted. But now with COVID, everything accelerated that. Then you have the health coaching component, where there will be someone to help you with your exercise plan and diet plan. and provide the nutritional and exercise guidance. Then you have the value-added services, things like medication delivery. The patient, if he's having a virtual consultation, ideally you should not go to the pharmacy to pick up his medication. So these are basics that you need to figure out when you're trying to provide telemedicine consultation to have medication delivery service, because you're providing the patient with the integrated care. The lab and radiology, and that's something that some of them can be provided at the patient's house, and it depends on your business model. Each country has its own challenges, and some of them can be done in the facility. Then you have the referral and the appointment booking when needed. If the patient was referred, you should be helping this patient, like hand-holding them into the care journey until they manage their episodic care, and then they come back to the program. So that's how it would look like the chronic care of the future. But we will go and dive deeply in that. First thing, it starts with risk stratification. Now, when you're going to manage a population, you cannot give the same level of service to everyone. And that's why it's very important to put your patients into buckets. Some of these risk stratification models are done by systems. That's amazing. If not, then it's done manually. When the patient is visiting the doctor, they ask them some questions, and based on these questions, they put them into the right bucket. Based on the patient's bucket, it will determine how many times he will be seeing the doctor, what tests he will be doing, what's the frequency of the interventions between the virtual care team that they're managing this patient and the patient. So, and also will determine the cost for the service that you are charging for. Because if you're providing any of these services, you will definitely be providing it in either a fee for service, where when you intervene or take an action, you bill for that, or you will be doing a subscription service where they will subscribe for this service and you will take care of them, or you will have something like a capitation model, similar to the Kaiser Permanente model in the US. But again, it's not only the clinical service utilization, but also the billing will be impacted. One of the most interesting things that I have realized in the chronic disease management in Mediclinic, in 2020, we implemented our chronic disease management here, and we had immediately 1,163 patients. This came from the government due to the lack of access. And what we realized, if the patient is sitting at the wrong risk level, they will tend not to comply with the treatment plan. So if the patient, you're trying to provide them high risk level service, while they are at low risk or a medium risk or the wrong risk, they will tend not to comply with the treatment plan, and you might find them also neglective. The ones that they were really at high risk, they were in real need for the service, and they were always following up if we missed anything. Hey, when I'm speaking to the doctor, when the nurse is coming to visit me, they are looking at this service as safety net. This is how the patient journey will look like. And here I just took that from one of our partners just to explain to you. I removed any branding there, but just to explain it to you. So it all starts with the patient and the patient onboarding, and that's something starts around here. This patient onboarding could be done virtually by giving the patient a link and telling him what to do. It could be done by visiting the patient at his home with the doctor or nurse, or only nurse, and help him with the onboarding. It's always important to create this rapport between the patient and the doctor, or the patient and the care team who's looking after him virtually. And after that, the patient will start entering his readings, reading his content, talking to the doctor. And this talking to the doctor could be a scheduled teleconsultation as part of his treatment plan, or it could be an intervention. As you can see here, if intervention is needed, it goes back to the data input. So we will tell them, like, we see that your reading is high, either repeat it, or they will adjust their medications, or they will tell them you need to come for a visit, or we will send you someone to check on you. It really varies, the interventions. We'll come to that in later at other slides. So The patient will be in this program, and it depends for how long. He could be discharged if he's stabilized, everything is perfect. He could be also downgraded to a lower risk level where it will require less interventions. So, for example, if he was having 10 services happening when he was high risk, maybe it will be one service, and maybe every 6 months. It will be just to maintain his condition. It depends on the condition. I'm just giving you an example, but it's really variable. Now, while the patient is doing all of that, the doctor will be reviewing this data, and they will be monitoring those patients. It could be the doctor, it could be the nurse, and they will be intervening when needed. Now, the question from Frank that I really liked, he was asking, where do we use the AI? I've seen multiple uses of AI, and we use AI in multiple areas. One of them is radiology. That's not a consumer-facing innovation, but it's a medicine innovation, where the radiology AI is able to identify things that we need to. It would require us multiple scans to be able to identify it or find it, which is good. But what's really important in this remote patient monitoring, that we use AI to focus on the patients that they really need the intervention and the monitoring and the care services. If you have 1,000 patients, you don't want to keep reviewing this 1,000 patients' readings all the time. So you might have anything between 10 to 15% where you really need to look at them and see what's going on. If you would just see the other 85 to 90%, it would be a waste of time because they are stabilized. The readings are fine, everything is fine, they are doing what they're supposed to do. You're having the scheduled calls with them, so everything is fine. But the ones that they are not taking the reading, or they took the reading and it's outside the ranges, it requires interventions. That's where you use the AI to prioritize that. And to be able, based on this data, to predict what could happen in the future. That's why you need the AI. Now, AI is a very tricky thing, and many companies, they talk about AI, but they might not really possess real AI. I will talk about the most innovative AI that I see as of today. That's the Tesla autonomous driving. And just try to imagine that. You're driving a car, and the car is telling you, I will go left now. And you find the steering wheel is going left. When you see the left is not clear. So you take the wheel and you bring it back to the right, or you keep it straight. So the AI told you that I would like to go left, and you gave immediate response. You said, no, stay in this way. Or you left it. It means that the AI is right. Once you move that wheel, you are telling the AI that your assumptions were wrong. You need to change your algorithm. And that's where you will have the machine learning. Sadly, in healthcare, as of today, we don't see that much. We don't see the same AI algorithm in Tesla, and the continuous communication between the AI and the provider, which is really the driver in that. And I stress many times the importance of provider. There are many airplanes that can travel in their own, but you don't see any airplane without a pilot. And I don't think you would go into a plane without a pilot. So it's very important to have this continuous communication loop between the AI and the doctor. And I'm not saying one doctor, many doctors, similar to many Teslas. So the AI is used here mainly to focus on the patients that they need the care, to predict what could happen, to show you early warning score and other things that we'll talk about in the future slides. So what else is there? What's really innovative about the chronic disease management, and what can be used to monitor them? Now, the monitoring is very interesting bit, because that's where I want to tell you about 3 types of patients. So you have a patient that he doesn't like this telemonitoring. He will never do it. He will prefer to have just the normal consultation, whether it's virtual or physical, but he's not gonna go for this amazing technology. And that's normal. We should not push them. And it always goes wrong when you push these patients to use these kind of technologies. Then you have a second type of patient. He's willing to use technology. He is having his own device at home, whether it's a glucometer or blood pressure reader, and he's willing to take a reading with this device and insert it into your app. This app is used as a medical gateway where it takes the readings and show it to the doctor. Then you have another kind of patient, and that's a very interesting patient. A patient that likes connected devices. He would like to have a device to take the reading and the reading to be transmitted directly. He doesn't want to do much intervention. He's into technology, but he's in a very advanced technology. And we see the advancement happening in the IoT devices as of today, especially in remote patient monitoring. I'm not going to mention any devices by name, but there are now some watches that you can wear, and it gives you all the patient readings, FDA Class 2 devices. So the patient will be sitting at home, watching his TV, doing his normal life routine, while you are getting a stream of all of his readings, whether you want it every 30 seconds or every 6 hours. I've seen variability in that, and that's amazing. That's very beneficial. That's based on the patient condition. Some of them even water-resistant devices. I've seen very interesting devices in the Arab Health conference in UAE. Those devices, as you can see here, is variable. It could be mobile apps that takes the patient readings. It could be blood pressure monitors, glucometers. These are all the devices that you have. And one of the other things for these patients that you have now, and this has started to be common, it's called medical gateway or smart medical gateway. So this device is similar to this one or this one. You will have it as an appliance at home. The patient will take his reading, whether it's a temperature or blood pressure reader, and he doesn't need to use a mobile app. The medical gateway will pick up his reading and show it to the team doing the telemonitoring. This is, I would say, this is one of the things that's getting advanced in telemonitoring. But the most advanced is the ones that you don't do anything, and all of these readings are going to the remote patient monitoring team. So how these platforms look like, I mentioned that it has smart RPM, smart remote patient monitoring. It has alert management where you configure rules if the patient reading was so-and-so and he's high risk, then do that. And here the alert management, it could be to notify the patient to take the reading again, or it could be to notify the doctor there's something wrong, and the patient and doctor goes and check what's happening. Or it could be an escalation. Maybe someone in this command center or the facility was supposed to do a certain intervention and they didn't do it. So you can configure even an automatic escalation in case someone was supposed to do something and he didn't do it. It's very, very important to be focused on the patient safety and quality in this remote patient monitoring services. Early warning score, early warning signs, and all of that. It's very, very important to have systems that has all of these algorithms, AI algorithms. That's what I mentioned to you. Structured interventions. This one is important. So part of developing the AI, that you need to have structured interventions. Your intervention should not be free text. It should be a certain action or consistent, so the AI can learn and develop. So when the patient reading was high and he was at medium risk, the doctor did 1, 2, 3. All of that should be structured data, and the doctor should be able to pick up his intervention, or the nurse, and explain the outcomes in the most structured way. And that's where the IT team and the business analysts should really analyze all of that and help and empower the doctors to have these structured interventions, because that's what will build the AI algorithms. Predictive analysis, you mentioned that as well. So those are the remote patient monitoring platforms, and those are the basic features that you need to have there. So digital health and chronic care, how does it work? So here, this slide is a bit elevated, but it's very interesting. So it starts all with the patient onboarding. creating the treatment plan, what the patient should do, when he should do it, what tests, frequency of the appointments, all the things that he should do. Then there is a patient engagement, the team that they will manage these patients virtually and the patient, how you will engage that. Then you have the training of the medical devices and apps. If you're going to do remote patient monitoring, you need to be able to train them on how to use it, how it works. I explained that there is a nice wearable that can take the reading while you are sitting doing nothing. But what if you were playing basketball or playing football? Does that mean that's your real heart rate? So there should be some guidance on how to use these devices, when to use the device, how to take the reading, and all of that. It's very important to do this training. And this can be done virtually or physically. Patient entries, that's the second phase. So now you onboarded the patient, you have the treatment plan, you provided the patient engagement, the team knows the doctor, the patient knows the doctor and nurse and all the team taking care of him. Now the patient is going to enter the readings. And here you need to have automatic reminders for them. Either you set it from the system and you remind them, or it could be something that you ask them to configure it, but they should be reminded on what they are supposed to do. And as a healthcare provider, you should be able to see what they are supposed to do. So for example, they are supposed to take 10 readings for the next week. And you need to have 10 entries. You need to be able to see 10 entries were required and 8 or 9 or 12 were entered. There is usually manual entry and automatic entry, as I explained in the earlier slide. It could be just holding the app and inserting your vitals, or it could be automatic reading, all going from the amazing IoT devices. And then you have the virtual rounds, the actual telemonitoring. That's where the patient review will be happening. It could be manual, it could be using amazing algorithm. It's valuable. My advice that you start from the basic and you build on top of that. You don't need to start from something advanced, and you don't need to start with big number of patients. You start gradually and you keep building up. But the patient reviews, the first batch, I would say, it will teach you a lot about what interventions that should be automated and configured in the system. You will have the missed readings and the interventions for that, the outside of ranges readings, and the early warning scoring. That's if based on these readings that you're looking at, you're expecting the patient within a certain period to go to this zone, and then you intervene before they go into this zone. So the virtual rounds are very important. It's a human intensive. If you don't have a strong system, it's very smart and it's not really human intensive if you have a smart system. If you don't have it, you will realize that you have a nurse, for example, going in each patient profile for 2 to 3 minutes to review his readings and make sure that everything is correct. The last bit is the quality management. There should be AI-based reviews. This is very important. You should have another algorithm which is checking all of that and making sure that everything is going well without you as a human intervening and initiating that. It should be system-based, where it's checking the treatment plan and what's actually happening for this patient. What are you delivering? There should be the escalation system. If anything is missed, to be automatically escalated. You should have random quality checks. The random quality checks, I recommend that to be human-based, where you are checking maybe 1 to 5% of the patients and making sure that everything is going in the right track. So the outcomes, what will be the outcomes? That's I was talking about all the things that we will do and how we will do it and all of that. The outcomes definitely is the health re-engagement. Many of these patients that they start engaging in their condition now, they will be re-engaged, that you're taking care of them. You're providing them the LTC. Improved and expanded access. That's very important. They don't need to go to the hospital to access doctors. One of the things that we did recently is a pilot of chat teleconsultation. We did it on a small group, closed group, 700 patients. And we wanted to see what will happen if we are providing immediate access to a doctor through just chatting with them. And the outcome was very interesting. We realized that the patients were engaging with the doctors all the time to ask them questions. And the doctors were actually able to engage with multiple patients because they can chat with multiple patients. So he can answer this question, then jump to the next question, and jump to the next question. He doesn't need to sit in this chat teleconsultation for 20, 15 minutes. He can just answer you. So it's very important to provide this expanded access to the patient. The primary care enablement, that's where you have the primary care doctors. They can be virtually available at any time, and they look after your conditions, not only one condition. Better disease control and management of cost reduction, healthcare services utilization reduction. That's definitely when you're taking care of this patient, you'll have less IP, OP, and we'll come to that in the next slide. Patient satisfaction, patient infections reduction. This happened a lot in the COVID period, and I would say in one of our programs called a chronic at risk. We are doing it with the Department of Health here, and we have seen the patients that they were not going to the facilities, they were not getting sick with COVID, which was amazing. Versus other patients that they had to come to our facilities, and they were exposed to COVID. This is a case study that's from my earlier company. It's a company that I helped building. Very proud of this story. So we built our remote patient monitoring system, part of the Dubai Future Accelerators initiative by the Dubai Future Foundation. You can Google Dubai Future Foundation. It's very interesting. And we were able to build the remote patient monitoring system from there. I built it in 2017 actually, and we were awarded a pilot with the regulator, and which is the Dubai Healthcare Authority. And we took license from Johns Hopkins University in the US to manage this program in a very structured manner. And the outcomes were very, very great. So we have seen reduction of the overall claims cost, 40%, reduction in the OP, outpatient GP consultation, 30%, reduction in the emergency visits, 35%, reduction in ambulance utilization, 30%, reduction in hospital bed days, 30%, reduction in specialist consultations, another 30%, and reduction in the admissions, readmissions, 15%. And the most important thing, the patient satisfaction was 90%. This was a very, very interesting case study. And we had at that time a third-party company to validate this data. And with that, you will have the references there. I will share the presentation with Dr. Jefferson. He will share it with you. And thank you for your time, and I'm happy to answer any of your questions.
Thank you, Ahmad. Thank you very much for your excellent presentation. You give a wide view and also a detailed approach on chronic patient management. Very, very interesting. Several points that you made are really interesting. Enjoying your example of the AI and the driver. Really, the provider must be listened by the AI systems to change what's not going well. Very nice. Before we go for the questions, and we have a lot of questions, just let me remind that we have this flash course series. We are now in the first edition. The next one will be on September 22nd. We will announce it in due time, and the third one this year will be in November. These flash course series are sponsored by the International SOS through a restricted grant. So we thank you very much for International SOS for supporting our educational activities. And also those of you who are participating in this meeting today, if you're not a member yet of the international side, please go to our website and become our member, become a colleague of us in this wide international society, and take the benefits of being a member. This meeting and the several other meetings that we do in the international side and in the education program They are being recorded and will be available to watch just a few days after today. So those of you who want to review or were not able to go to the end of this course today, and also tell your colleagues that they can watch this excellent session free of charge. So please go to our website, become a member, and enjoy all of our offers. Ahmad, we have several questions here. Let me go up just to go to the first one. And the first one is here from Alfred. Alfred, just let me get the full name here, not being able to get. Alfred Camara. What are the problems faced by caregivers of patients with chronic disease in chronic care strategies? You have to unmute.
What are the problems faced by caregivers of patients with chronic disease in chronic care units? I would assume that you mean the remote patient monitoring units, because I cannot answer for the normal chronic care.
Yeah.
Or the virtual facilities. The main problems that we see is the patient engagement, is the patient adherence and compliance with the treatment plan. And we realized that it has multiple reasons. Some of them, as I explained, related to mental health and not really providing them with the required support if they have multiple conditions, especially if it involves cancer conditions. The other thing that we realized, if you kept changing the treating team, the virtual treating team, it will also cause this disengagement with the patient. So it's very important to assign a primary care doctor for this patient. And if this doctor not available for any reason, he should have a secondary doctor. And I don't mean a specialist, a secondary care doctor as a secondary care, I mean a secondary assigned doctor to him. So he will know that my condition is managed by Dr. Joe. And if Dr. Joe is not there, I have Dr. Frank to take care of me. You should not make him feel that every moment you're introducing a new doctor. It will deteriorate this engagement and you realize that he doesn't really care.
Okay, wonderful, thank you. And this question comes from Frank Kalberg. How are roles of healthcare professionals changing as platforms and technologies are improving?
Sorry, can you read again, Jefferson?
Yes. Kalberg wants to know the platforms and technologies are always modifying, improving. And what happens to the role of healthcare professionals, if I understood well the questions, when these platforms, or for these platforms changing? What are these, probably the insights from or the experience from healthcare professionals to contribute to these changes? How
the roles of the healthcare professionals changing as platforms, technologies such as are improving. It's very, very important question. And again, it goes back to the pilot and the airplane example. You will never go into an airplane, or at least the current population is not going to go into airplane, which is managed only by artificial intelligence. It's a doctor-driven service. And with all respect to companies like Awada, many companies are out there. They don't do the example that they explained about Tesla. They might tell the patient, most probably you're having fever, you're having this condition, or you're hypertensive. But their algorithms are not developed or developing similar to what you would see in AI in Tesla. So I believe that the service will always be doctor-driven. Even if the most advanced AI is there, it will always be doctor-driven. But what the AI and all of these tools will help, it will enable the doctor to come to his decisions quicker. Instead of doing lots of tests, unnecessary tests, he will be able to get the insights immediately and take a decision. it will be always enabler. But I don't see at all the healthcare professionals being eliminated by these technologies, even if they became advanced, which I don't see it because it's not really advanced as of today.
Okay, thank you very much. There is a question here from Stephen Shug. Stephen, do you mind to rephrase it again? Because I think you were questioning something, was related to something that Ahmad was telling. So I'm not sure that we can, understand the context.
I understand.
You understand, please, Ahmed?
Yes,
go
yes.
on.
This is really related to the treating physician, Dr. Jefferson, because
right.
the treating physician usually will tend to take control of the patient. And when they are moving from healthcare to organization to the other, they take them with them. Yes, we are talking about all kinds of healthcare providers. The transfer should happen within an integrated healthcare provider, meaning that this independent provider doctor should be working under this organization, whether he's fully employed by them or he's working as independent and practicing inside this hospital, it doesn't matter. But he should be sitting under the same umbrella. Because if you are not really in control of this doctor and his practice, again, you'll find that the virtual doctor is going to a different direction than the physical doctor. I wouldn't say the physical doctor, I would say the treating physician.
Okay, thank you. There is another question from Frank Kalberg. He wrote, thanks for sharing very interesting experience and ideas from the work you do, Ahmed. And he says, I understand that much innovation is going on in healthcare that helps people both regarding treatment and prevention. That's very positive. In Switzerland, there has been an increase in healthcare premiums for some years. How do we manage this dilemma in order to first keep up innovation in all healthcare areas and help everyone even better? And second, keep insurance premiums payable for all?
Very, very interesting question. Frank, it would be great to connect on LinkedIn. I really like your questions. The good thing that we are operating in Switzerland, I can tell you how do I see the future healthcare models. The current healthcare models are fee-for-service. I believe that the future healthcare models will be value-based, capitation-based, and all of that, where you will utilize technology to the max, where you can manage the patient better, preventive care and all of that, and get paid based on managing those patients better and having better health outcomes, not to be getting paid on the number of visits that you are doing. Because what I realized in these models, and with all respect to all healthcare providers, the private one worldwide, but they tend to make more visits to make more money. And the average claim value might be low, but the number of visits might be high. And as insurance, what they tend to do, they become a bit aggressive on the rates and all of that. So I think the future will be, it doesn't matter how many visits he will come to me, as long as I'm taking care of him. And the innovation at that time, what it will do, it will help you to prevent this patient from getting sick, because you get paid, it's a value-based model. You get paid on managing this patient's condition. So that's how I see it in the future. And you will see multiple models where you will see a virtual gatekeeping model. That's another hybrid model between all of that. The patient is feeling sick, he speaks to a doctor online, and the doctor online can refer him to physical or virtual or anything like patient triage, online patient triage.
Okay, thank you. Another question from Kalberg. I'm learning that there is increasing focus on finding purpose, both for individuals and organizations. What is being done by whom to help, for example, young and elderly people to find purpose? To what extent do you think that helping people find purpose can help people strengthen physical and mental health? And I just follow on the next question that I think it's related. And regarding to healthcare professional, it's the work of they do, it's important challenge. And what do healthcare professionals need themselves to stay healthy so they can keep helping people?
I'm not very clear in your question, Frank, but I'll try to answer it to best of my understanding. So what's being done by whom to help, for example, young and elderly people to find purpose? To what extent do you think that helping people find purpose can help people strengthen physical and mental health? See, it all goes back to the mental health. So in the chronic care, the patients, when they have multiple conditions, they just give up on themselves, and they will be counting days on when their misery will end, or they will be in autopilot mode where they feel like this is how I'm going to be. And that's where the mental health plays a very, very important role. Not only the mental health, but also the virtual team that they are dealing with. They need to engage him to live outside his sickness. He cannot just focus 24/7 on his sickness. And that's why you will see health coach helping him with the exercises, with the patient education, will help them with their diet, maybe eating interesting food, or just taking care of their health and eating healthy food. But the mental health is the most important, because they listen to them and their concerns, and they work on their symptoms and anxiety, depression, all of that. And that's where you put them in the right track, and they start finding the purpose. They believe at that time, when they have all of these conditions, that their journey is coming to an end.
Okay, thank you. We have, sorry, just moved here. We have a question from, just changed here. Let me go back and find the question from, just a second. From, here it is. Fabian Schneider, can you tell us more about the value-based model, Ahmed?
I explained this one in the about the capitation model. That's capitation model, like what you'd see with Kaiser Permanente, similar to all of these value-based models. But when you see the word value, it's about the value. What are you delivering for this patient? As I explained, that as of today, many of these healthcare models are fee-for-service. So the insurance is paying you when the patient is sick and coming to you. So it's not preventive. And the more the patient comes to you, the more that you get paid as a private healthcare company. The future model is preventive. You get paid a flat fee, whether the patient gets sick or doesn't get sick, deteriorates or not. So you will be incentivized to make sure that this patient is always healthy. Because it's similar to DRGs, I would say. DRG, I consider part of the value-based model, but it's not preventive, but the same idea. If the patient is sick, you lose more money, and the patient is not happy. So these value-based models prevent that from happening, and it enables actually preventive care models.
Right, there's a question for Zainab Adinvala. Do you think there is an opportunity to include digital health to patients who physically cannot come to hospital? Example, people of determination. The new UN determination, the new sustainability goals mention inclusivity and accessibility. Can we make a digital health model for people of determination in Dubai and include, when it comes a new question, and include that project in sustainability report for a corporate hospital?
Yeah, this is the people of determination is a very interesting topic for me personally, because of a family member. But I can tell you, digital health is a huge enabler for these people of determination. No, they don't need to come to the hospital. And yes, there could be programs for them. What we try to do is creating a matrix of the people of determination disabilities. And against each disability, we're providing a solution for that. We didn't implement it yet, but you will be surprised with what technology can do. Where Microsoft, I would say, and a couple of other companies, they have done a great deal of enablement for people of determination. It starts from transcripting and immediate translations. I've seen a feature in MS Teams where it will automatically translate the slides that you're presenting. So if you're explaining something to a patient, it will automatically switch it from English to French to another language. Yeah, so but I believe in that, and yes, I believe that it could be something provided for sustainability. Yeah.
Right. Thank you. Well, just for letting people know, we have some unexpected situations in this first edition. One of our speakers, Richard Daslet, had probably, I'm not sure who, but later then we gave this information. He was involved in a car accident, nothing bad. He was fine, but he wasn't able to join us. And Emmanuel Awada was also to participate here today with us. He was delayed in a flight, so he didn't manage to get to the hotel in time to join us. But both Richard and Emmanuel will be together with us in the next editions of our flash courses. And of course, Neja and Ahmad did an excellent job, together with us, managing to bring their knowledge, their experience, and their visions, which were excellent. And I can't read here a phrase from our attendee that's very active, Frank Oliver. Thank you very much for all your participation, Frank. And he wrote that this webinar was really extraordinary. So many golden nuggets throughout the events. I learned a lot, and this hopefully is something that everyone felt like this also. So I just, before ending this webinar, I would like to make a question for you, Ahmed, from your comments, and also for Neja. It's a question that both of you could answer related to the topic that you presented. We always know what to do. Sometimes, I mean, we several times you know what to do. We learn from experience. We learn from science. We learn from sharing information. But sometimes it's difficult to know how to do it. So when we talk about how to do it, we have to face challenges. So my question to both of you in your talk is, what are the main challenges? Would be the challenge that you really come to your mind for the implementation of the standards for services for organizations, and also for you, Ahmed, for developing or for implementing chronic disease management programs. Neja, please, if you could go first.
Okay, thank you for the question. First thing would be, I would repeat the word trust, and what can we do as professionals or experts or people involved in the process that we can strengthen the trust into the telemedicine and telehealth. So this is on my mind a lot.
Okay, thank you, Neja. Ahmed?
I think Dr. Jefferson, I think we need more of these sessions. Why I came here today, it's almost 7 p.m. in UAE, but I'll tell you why I came here today. We as MediClinic, we're expanding in the virtual health. And when I'm trying to hire people that they understand virtual health, it was really a struggle. I think what we really need to do is to create this knowledge base. We need to expand and share the knowledge. We should not be very overprotective of our knowledge. We should share it and enhance it and increase it. We need to create a big community. Virtual health is going to expand numbers that I see, huge numbers, not specifically in chronic care, everywhere. And when you look at the workforce that we have today, I see there's a huge gap between the workforce and between the future market demands. I think what we really need to focus on, and I was really pleased to be here today, is to build this workforce to meet this gap. Again, you can reach out to me. We are always hiring. We are always trying to find talent. It's not easy to find them. The market has a huge gap. I believe that this is a very good platform to educate everyone and to bring them to the right level. I see also that you have very nice, I was checking the master programs and the other programs that we have in the International Telemedicine Society. And I encourage everyone here today to go and have a look at them and start your education journey. It could be a quick course like what we had today. It could be a diploma, a bachelor degree, a master's degree. Actually, I don't see bachelor programs, but there's lots of master programs in the education and courses page. Maybe Dr. Jefferson will share it with you. But I totally recommend that. You really need to build the knowledge. You need to understand it better. Maybe you will learn it. Maybe you will be better even than myself, and that's what I'm eager for. I meet lots of people, and I was pleasure to meet Neja when the MENA Telehealth happened in UAE, and it was great to talk to her and to hear from such brilliant brains and minds. I encourage you that you really need to invest in yourself and educate yourself. We need to create the next workforce for virtual health, telemedicine, all of these amazing technologies and future delivery models.
Thank you, Ahmed. I'll make my and ask the words from one of our participants, Stefan Schuck, who wrote, "Hence our two speakers add even more opportunity, proving their excellence." Thank you very much for you, Ahmed, and for you, Neja, for being with us in the first edition of our Flash Course series. Thank you for all attendees, all participants that are here. And a special thank for those who have actively participated in this course. This is the idea, to bring to you the knowledge and the experience of our members, to share this knowledge and experience with you, and open the opportunity for you to bring all your comments, all your questions, or informations that you like. So I invite you to connect with us, be a member of International Society. Check for our next meetings, and again, I'm also thank you, International SOS, for being so supportive to our education program. So thank you very much for all the best for you. Take care and see you in the next opportunity. Bye bye.
Bye bye. Thank you.